cardiogenic shock. When heart can't pump effectively enough, low CO whole purpose of the heart is to get adequate cardiac output. Common causes: MA, damage to the heart. Cardiac tamponade, fluid around the heart so the heart can't stretch as much as it needs to because it's reading that resistance. Cardiac arrest, that state where it's not getting the blood and oxygen that it needs.
Electrolyte imbalances,
V-fib or V-tach. Pathologic changes in valves. Complications of cardiac surgery. Cardiomyopathies, HTN, ETOH, alcohol, infections, or ischemia. What would the RN do? Call a rapid response. Apply O2. Apply O2, get VS and assess LOC. Get EKG. Draw labs for cardiac enzymes. Treatment. Measure lactate level. Normal level less than 2.0 mol/L***. Concerning when elevated, rightwards arrow means person is using metabolism W. Out O2. O2 as prescribed, IVF boluses of 30 milliliters per kilogram of crystalloids. NS/LR. Administer vasopressors if hypotension persists after fluid boluses have been administered. Goal MAP greater than 65 mm Hg. Monitoring their cardiac output, their kidney function, making sure they don't go into like kidney failure, checking their skin, frequent vitals. If he starts to lose consciousness or that blood pressure gets any lower, what are we going to start CPR? Septic shock. Forcer's criteria. Tachycardia. Systemic inflammatory response. Tachypnea.
leukocytosis, 1200, leukopenia, 4000. Bandremia, 10%. Leukocytosis.
Hypothermia, less than 36 C. Or hyperthermia, greater than 38 C.
Leukocytosis.
Leukocytosis is an elevation in the absolute WBC count, greater than 10,000 cells L. greater than 11,000.
Bandremia 10%。Bandremia 10%的圖片搜尋結果。
Bandemia is the term used to describe too many white blood cells being released by bone marrow into the bloodstream. Hypothermia, less than 36 C, or hyperthermia, greater than 38 C. Once you see that pattern, that's when you're probably going to order your blood cultures a lactic acid to see if you're going towards sepsis and to see if you can find a source of the infection, and if you don't catch it, it's gonna be going into septic shock. Anyone have questions about cardiogenic shock? Excellent. Alright, now we're gonna go into septic shock. Oh god, how come questions? It should, but there's not enough blood around it that's getting out, so that's why it's still low. So it's trying to compensate with constriction, but it still can't keep up, right? Cause we're in a low perfusion state. Alright, well bye. He said it's going to start to take a little bit of a dip, but it's still going to be within normal limits, so it's like a less than 10-point drop on your septic shock. So sepsis starts with SIRS, and this is when you have that inflammatory response in the body, and it's before you know where the infection is coming from. So signs of SIRS could be tachycardia, tachycardia, leukocytosis, or leukopenia. So your white blood cell count could be high, or it could be low, either one, and then hypothermia or hyperthermia. So they're either going to be cold or they're going to be warm. It's not on the side you operate again. So those are going to be your 4 criteria that something is going wrong. Once you see that pattern, that's when you're probably going to order your blood cultures a lactic acid to see if you're going towards sepsis and to see if you can find a source of the infection, and if you don't catch it, it's gonna be going into septic shock. Septic shock. Number 1 killer in ICUs. Number 1 killer in ICUs, type of vasogenic shock, so it has to do with that vasodilation. Massive infection causes vasodilation.
MAP drops below 60 mmHg, min. MAP for organ perfusion.
You want to increase the MAP, and what is the minimum? Call MAP 60-65. 65 will be better. If 80, and probably come down under pressures, because the higher you are, the more vasoconstriction you have, and remember, the more vasoconstriction you have, the more afterload you have, so the heart's working harder and your broker may not be getting as much oxygen as they need because it's so clamped down. So you really just want to try to keep it right around that 65 mark. Septic shock. Early signs. Early identification and treatment is key. Normal BP to mild hypotension. Increased HR, compensating. Tachypnea. Alert and oriented. Asterisk possible fever and or increased WBC. Warm flushed skin, only for septic. You'll be cool and pale with cardiogenic shock. With septic shock, the heart's still working okay, but everything is just so dilated and the infection is taking over that they're going to be warm flushed, a risk factor for septic shock. So this fever and warm flesh skin is going to be some of your earliest signs. So you might have a patient that you know had surgery and you're like, oh well, they could be tachypneic and having increased heart rate because they're in pain, but you cure the pain and they're still having these symptoms, and now they have a little fever, they're warm and flushed, so you really want to start looking at and talking to the doctor about it. Late signs: worsening hypotension, tachycardia, rapid shallow breathing, cool, pale, edema to skin, lethargic, oligoria to anuria, from low perfusion and the compensatory mechanism. We're trying to hold on to the fluid. Septic shock is like abdominal surgery, you know, having central lines, anything that could be a source of infection. You could have urosepsis, so at UTI, that's gone undiagnosed. So these are your risk factors and the kinds of patients that you want to be looking at. Interventions: generalized nursing care for shock. Monitor perfusion and cardiac function. Sudden symptoms implying embolism, i.e. acute dyspnea, chest pain, CP, anxiety, restless. Frequent vital signs. Hemodynamic monitoring.
CVP levels normal 二至六 mmHg 2等於 FVD 6等於 FVE.
Monitor for changes in LOC mental status. Strict INO.
Oliguria 等於 U 波30 ml/h.
GI assessment: ileus and bleeding. Bed rest. Supine, possibly elevate legs 20, white bullet. Calm, quiet environment. Vasoconstrictors, used for hypotension.
Norepinephrine.
Phenylephrine, epinephrine. Modified Trendelenburg, large bore IV. Greater than 20 gauge. O2. Greater than 20 gauge.
O2.
Mechanical vent. Severe, ICU.
VSQ.
Rest, decrease movement.
Monitor IO.
Want greater than 30 milliliter HR, fully cath.
Iron dose.
Should have normal body temp, maintain SBP above 90. Labs, ABGs, lactic acid. Should be between 0.51. Serum glucose, cardiac enzymes, coagulation studies. Treatment: cardiogenic, increase contractility and reduce after load, Lasix. Septic, IV fluids, vasopressors, antibiotics, low-dose corticosteroid. Medications to know: Vasoconstrictors, used for hypotension.
Norepinephrine.
Phenylephrine.
Epinephrine.
INH.
Monitor.
BP and HR, infiltration of IV, urine output. Inotropes, increase contractility, dobutamine, but they also can vasoconstrict to a certain degree.
Dopamine. Dobutamine. Monitor.
BP and HR, CO, urine output. Vasodilators, reduce after load and SVR, only for cardiogenic shock. Increase after load SVR, bring down blood pressure.
Nitroprusside.
Nitroglycerin.
Monitor.
BP, nitroprusside, greater than 72 hours on med can cause thiocyanate poisoning.
Nausea.
Confusion, decreased reflexes, muscle spasms. All these meds need an infusion pump. Early versus late signs of septic and cardiogenic shock. Medications for shock and DIC. Recognize signs and symptoms of sepsis and shock. Recognize signs and symptoms of DIC. Nursing care for shock and DIC. Causes of DIC.